Once more, welcome to the presentation of this work titled The Sickle Cell Trait and Reproductive Decisions Among Youths in the Faculty Division, presented by Dr. Nde Fon Njweng, supervised by Professor Doran Bania, and co-supervised by Associate Professor Njunda Anna. This work is currently under review to be published in the Pan-African Medical Journal. We shall adopt the following outline. Sickle cell disease is a group of inherited hematological disorders characterized by the presence of sickled hemoglobin. This mutated hemoglobin arises from the single substitution of glutamic acid by valine at position 6 of the beta-globin polypeptide chain. Sickle cell anemia is the commonest and most severe form of sickle cell disease. It is inherited when the hemoglobin S genes are taken from both parents. Note that it is eminently preventable if one parent has the normal hemoglobin AA genotype. However, it is still one of the commonest genetic causes of morbidity and mortality. Globally, over 300,000 children are born with sickle cell disease yearly, and 75% of them are from sub-Saharan Africa. Unfortunately, up to 50 to 90% of these children die before the age of 5 years. How sad could this be? Again, the global prevalence of the sickle cell trait ranges from 10 to 40% according to WHO and Pitt et al. Moving to our context, ladies and gentlemen, Cameroon is the 6th African country with the highest sickle cell disease birth prevalence, with over 7,000 births per year. Jamshi et al. Reported from a study in Yaoundé a sickle cell disease stroke prevalence of 6.7% with a 25% annual recurrence rate. This reflects the severity of sickle cell disease. Also, the prevalence of the sickle cell trait ranges from 18.2% to 30%. Even though sickle cell disease is preventable, ladies and gentlemen, today, especially in the low-income countries, it still reduces the quality of life and leads to loss of millions of disability-adjusted life years. Again, sickle cell disease reduces life expectancy by up to 30 years, according to Pitt et al. The burden of sickle cell disease is constantly on the rise because of low family income, limited public health funding, limited availability of disease-modifying agents like blood transfusions, penicillin, vaccination, and hydroxyurea. Actually, note that in Cameroon, hydroxyurea is used by only 5% of sicklers, according to Wonkam et al. In 2014. Furthermore, there is lack of awareness of both the disease and its prevention. To a lesser extent, the sickle cell disease burden is on the rise because of superstition. Mr. President, 70 out of 100 children believed to possess witchcraft actually had sickle cell disease in a study by Nzewi et al. In Nigeria. What then is the problem? In Cameroon, up to 16% of under 5 deaths are associated with sickle cell disease and its complications. Despite this, there are few sickle cell disease specialized centers. Also, poor reproductive decisions are being made. Premarital testing and counseling on sickle cell disease is available but underutilized due to lack of awareness. More so, there is limited knowledge on sickle cell disease and its prevention. Advocacy and colleagues reported that under 1/3 of Nigerians had good knowledge on the nature of sickle cell disease. Furthermore, few studies have been done in Cameroon to assess the knowledge of sickle cell disease and trait. However, a study by Nini et al. Reported that up to 86.8% of unmarried youths in the Boya Health District did not know their hemoglobin genotype. Why then this research? Although sickle cell disease is referred to as the first molecular disease, to date, ladies and gentlemen, only hydroxyurea and L-glutamine have been approved by the FDA. Prevention remains the best way to tackle sickle cell disease, especially in our developing countries. Carrier identification, therefore, and premarital counseling for sickle cell disease prevention is advocated by the WHO. In 2004 and 2005, respectively, Bahrain and Saudi Arabia instituted carrier identification as a law. And ladies and gentlemen, this halved the prevalence of sickle cell disease over 10 years. The success of such a program, depends on sickle cell disease knowledge, hemoglobin genotype knowledge, and the use of prenuptial counseling and good reproductive decisions in our study to seek and the so success of such a program requires that the youth make good reproductive decisions, and our study seeks to provide this information. We therefore sought to determine the prevalence of the sickle cell trait in youth aged 18 to 40 years in the FACO division, to assess the knowledge of sickle cell disease and sickle cell trait in this group, and lastly, to ascertain the reproductive decisions this youth would make in regards to sickle cell disease and trait. To achieve our objectives, we carried out a hospital and community-based descriptive cross-sectional study over a period of 4 months from January to April 2020. The target population encompassed youth aged 18 to 40 years residing in Limbe, Tiko, Boya, with sample collection sites being Limbe Regional Hospital, Tiko District Hospital, and Solidarity Hospital, Boya. In this study, we included consenting youths aged 18 to 40 years residing in Limbe, Boya, and Tiko. Potential participants who had been transfused within the previous 4 months were excluded. The proportionate to size, simple consecutive sampling method was used. Using the Cochrane formula, we had a minimum sample size of 288 participants with a p-value of 0.25. After ethical and administrative approval was obtained from the Institutional Review Board of the Faculty of Health Sciences, University of Boya, a pilot study was then carried out at Bonamusadi District Hospital, and the questionnaire was adjusted. Following radio announcements, participants were recruited at the aforementioned health facilities. Blood samples were collected for hemoglobin electrophoresis, then questionnaires were administered. Thereafter, blood samples were transported to the laboratory at Solidarity Hospital Boya, where hemoglobin electrophoresis was done. Participants were then contacted, and the results were handed at the sampling collection sites after education and counseling. Data was keyed in and analyzed using SPSS version 26. Continuous variables were summarized with means and standard deviation. Categorical variables were summarized using frequencies and proportions. For this study, we defined sickle cell traits as one abnormal allele of the hemoglobin beta gene. Carriers were defined as a person with a sickle cell trait. Sickle cell screen was defined as a test for assessing hemoglobin genotype, that is, hemoglobin electrophoresis in our case. Reproductive decisions was defined as the choice to become a parent, when, with whom, and how. This encompasses factors like abortion, assisted reproductive technology, adoption, and foster care. Premarital counseling was defined as therapy that helps couples to prepare them for marriage. And youths were defined as individuals aged 18 to 40 years. Ladies and gentlemen, what did we find? Of the 640 participants screened, 300 responded to our questionnaire. The participants had a mean age of 25.3 years, with two-thirds being females. About 87% were single, 84% had attained tertiary education, and just 1 out of 10 of the participants had health insurance. After screening, we obtained a sickle cell trait prevalence of 12.3%, and 87.7% had normal hemoglobin AA. The sickle cell trait prevalence of 12.3% obtained in the study was different from the 20 to 30% quoted for Cameroon by WHO in 2006. It's also different from the 26.4% obtained in a cross-sectional study by the European Network for Rare and Congenital Anemias. The larger sample size and encompassing all age groups used in their study could explain the difference. Of the population, 70% were females. This could be explained by the female predominance in our participants. 78% were carriers. 78% of the carriers were uninsured. This raises the speculation that uninsured youths carrying the sickle cell trait will be less likely to afford optimal medical care if they bring forth children with sickle cell disease. It is also worth noting that over 63% of the carriers had unprotected sex with no knowledge of partner genotype. Again, ladies and gentlemen, a quarter of these carriers do not ask for partner's genotype prior to starting a relationship. Behavioral changes towards sex is mandatory in the control of sickle cell disease and sickle cell traits. Having unprotected sex with no knowledge of partner genotype suggests that this youth will likely bring forth children with sickle cell disease, so the prevalence of sickle cell disease will rise if nothing is done. 96% of the study population had heard about sickle cell disease and 86.7% about sickle cell trait. This was similar to some studies done by Adewoyin et al. In Nigeria and Amide et al. In Ghana. This good level of awareness in the above studies is likely because most respondents were semi-urban dwellers and had exposure to the media. 87% of our participants knew that sickle cell disease was due to a red blood cell abnormality. This was similar to studies in Nigeria. Mr. President of the jury, 4% still had the belief that sickle cell disease is due to witchcraft or evil spirits. This was in contrast with the 25% reported by Olerawaju and colleagues in Nigeria. This could be explained by the stronger cultural beliefs and superstition linked to sickle cell disease in Nigeria. 3/4 of our participants had good knowledge on sickle cell disease with a mean score of 9.5 on 12. This good knowledge could be secondary to the semi-urban Of the married participants, 35% did not undergo premarital counseling because they did not have information on it or because they did not think it was important. This suggests a low awareness on the importance of premarital counseling. Over 95% of our participants agreed that everyone should know their sickle cell status. Note that 27% of the population checked or will check their sickle cell status because of the subsidized cost of this test, suggesting that decreasing the price of this test encourages screening. Over 3/4 of our participants did not know their partner's sickle cell status. Similar findings were gotten in Jamaica, in a study among African women where 78% did not know their partner's genotype. Over 92% of our population agree that hemoglobin genotyping should be routine in our hospitals once the concerned does not know his or her status. 76% and 68% agreed that partner genotype will influence marriage decision and having children respectively. About 43% of the participants decided not to have children again following one child with sickle cell disease. Very importantly, ladies and gentlemen, 22% decided to have children with another partner to limit risk. These results are highly suggestive of the high rate of divorce carrier marriages may result in after a child with sickle cell disease. This also points out how family size may be restricted due to the fear of having another child with sickle cell disease. up to 26% of the population decided to terminate the pregnancy following intrauterine diagnosis of sickle cell disease. This was higher in a study by Flanders, where 43% said yes to pregnancy termination. In this same study, 16% rejected abortion with viewpoints on it being murder. These differences could be attributed to the fact that this study was done in high school students, hence younger and less experienced. About a third of the population agreed to use contraception, non-childbearing options like adoption, foster care, or to use artificial reproductive technology to avoid sickle cell disease. Half of our participants agreed that the law agreed with the law restricting marriage between two carriers or marriage between a carrier and someone with sickle cell disease to avoid sickle cell disease births. In conclusion, 1 in every 10 persons in our study population has the sickle cell trait. 3/4 of the population has a good knowledge on sickle cell disease and trait. However, majority are unaware of self and partner genotype. More than half agreed that partner genotype will influence marriage decision and having children. A third of participants agree with the use of contraception, non-childbearing options, and artificial reproductive technology to avoid sickle cell disease. Ladies and gentlemen, the reproductive choices show that the goal of reducing sickle cell disease is compelling. Career testing earlier in life offers a less burdensome and potentially effective means to achieve a lower sickle cell disease prevalence in the population. We therefore recommend to the government to expand sickle cell trait screening programs, to subsidize the cost of hemoglobin electrophoresis, and to work towards advancement in medical technology so that technology like pre-implantation genetic diagnosis and intravenous fertilization could be available to widen reproductive options for already existing sickle cell trait carrier couples. We recommend to the health sector to advocate for early hemoglobin genotyping. So health workers should make efforts to request hemoglobin genotype once a patient with unknown genotype is in contact with them. We recommend to the scientific community that they carry out larger studies to get national prevalence of sickle cell trait and more research on preventive and curative options for sickle cell disease. To the youths, we recommend knowledge of your genotype and partner's genotype prior to a relationship, prior to sexual intercourse, and absolutely prior to marriage. Ladies and gentlemen, thank you for your kind attention.